I'm Sandy Werner. I'm one of the leaders of the journal club, the PTL. And this month is pediatrics, and I am really excited to have two articles that are really applicable to anybody who sees pediatric patients in their emergency department and does ultrasound. So the first article that we have is interpretation of cardiac standstill in children using point-of-care ultrasound. And congratulations to the authors for getting published in the Annals of Emergency Medicine just a year ago. And we have actually the first author and the senior author with us. So I have Dr. Yanni, MD, who's an assistant professor of pediatric emergency medicine at NYU Langone Health and Bellevue Hospital Center. And just for fun facts, we asked them all for fun facts. His wife just ran the New York City Marathon for the first time, and he got to watch and cheer the marathon for the first time. So maybe next year he'll be running it. And then we also have Dr. Tay, who's the clinical site chief of pediatric emergency medicine at Bellevue and the director of ultrasound research and scholarly activities at NYU Langone Health. And her fun fact is that she was a Girl Scout leader in medical school and sold over 300 boxes of Girl Scout cookies to her, her class. I think that's great. All right, so I'm going to let them take it away.
All right, so let me try to share with you all. Take a portion of the screen. And everybody can see this, right?
Yes.
All right, very good. So I have no disclosures, and like we said, the title of this paper was Interpretation of Cardiac Standstill in Children on Point-of-Care Ultrasound. So to begin, let's just start with a scenario. And let me just maximize this a little bit more so it doesn't get cut off. Geez. So you're in the ER and you're looking at this clip and you're resuscitating a pediatric patient in cardiac arrest. On the pulse check, the patient's pulseless, and you simultaneously obtain the parasternal long axis view of the heart that you see here. And so my question is do you think cardiac standstill? Just yes or no. And so do you think your colleagues would agree with your interpretation of this? Do you think everybody would agree that this is or is not a cardiac standstill? And so just for some background, point-of-care ultrasound, we widely use it to diagnose standstill and guide our resuscitations for patients in cardiac arrest. However, both ACEP and the American Society of Echocardiography don't have a formal stated definition of standstill. Furthermore, the definitions of standstill vary quite a bit in the literature. So, for example, some definitions include both the myocardium and the valves, whereas others say standstill only refers to the myocardium and allows for isolated valve movement, for example. And it does have further discrepancies as well, depending on the study that you're looking at. And then also, there are adult studies that only show moderate agreement on what represents standstill. So our objective was to measure the level of agreement among pediatric emergency medicine, or PEM, physicians when assessing POCUS video clips for standstill in pediatric patients. For our methods, we used a single online cross-sectional convenience sample survey that we administered to a listserv of over 2,600 PEM physicians. The first 3 questions of our survey solely asked the participant level of training and their degree of ultrasound experience. For ultrasound experience, we chose a cutoff of at least 25 ultrasounds based on the ACEP statement that providers should have between 25 to 50 quality reviewed exams in a particular application to achieve proficiency. The remaining 11 questions of our survey showed a unique 6-second clip of cardiac point-of-care ultrasound performed during pulseless arrest in pediatric patients. Each question simply asks, do you think this clip represents standstill? Yes or no. You had unlimited time to review the clip, and there was no right or wrong answer to each clip. We solely wanted to know how much people agreed with each other. For quality assurance of our clips, the study authors, along with an independent attending, all separately evaluated the characteristics of each video clip. We looked at the probe view, we looked at the wall motion, valve motion, as well as blood swirling. We specifically looked at these factors as these are all mentioned in the most specific literature definitions of standstill. Regarding our results, overall, we had 263 attendings and fellows of variable ultrasound experience participate in the survey. Of these respondents, complete survey data was 100%. No participants were excluded. 110 of those attendings had performed at least 25 cardiac point-of-care ultrasounds. This is going to be our primary subgroup that we'll be focusing on. As far as our responses, the breakdown of yes/no responses based on each clip is listed here, and it's split by the subgroups. Specifically, we're just going to focus on the attendings with at least 25 scans. If you look here, you can see that clips 1 through 9 had pretty marked agreement throughout, whereas clips 10 and 11 highlighted in red, you can see that responses start to diverge as to whether or not our participants thought this was standstill. So here, this table highlights the agreement across the first clips 1 through 9. In these clips, of note, wall motion does correspond with valve motion. So we can see that our primary subgroup meets good agreement. Even the attendings with 0 scans had acceptable agreement. The video on screen right displays an example. As you can see, both the walls and the valves appear to be completely static in this clip. As far as our stat, we chose Krippendorf's alpha as our agreement statistic because it can be applied to larger sample sizes and it can be comparable across different groups. Regarding this stat, an alpha of greater than 0.8 indicates good or ideal agreement, whereas alphas between 0.8 and 0.667 are considered acceptable, and alphas less than this range are considered unacceptable. Now, when we isolate for the agreement of only clips 10 and 11, which are the clips that show wall motion but absent valve motion, we can see that agreement hits unacceptable levels for our attendings with over 25 scans. This was also seen across all subgroups. The following table displays the agreement between our subgroups that are aggregated across all 11 clips. Notably, agreement across all 11 clips in aggregate does meet acceptable thresholds among our primary subgroup of attendings with greater than 25 scans. Here I have a slightly larger display of clips 10 and 11. So looking at these clips, we have what appears to be some minimal wall movement, but it appears that the wall movement is not enough to cause the valves to open or flutter. If we look at clip 10 on the left, 78% of attendings with over 25 scans recorded this as a cardiac standstill, while 22% of the attendings recorded it as ongoing cardiac activity. Now, if you look at clip 11, we have pretty much the exact opposite. 77% of attendings with over 25 scans recorded clip 11 as ongoing cardiac activity, while the remaining 23% recorded it as a standstill. For our conclusions, overall, while this investigation did demonstrate quote-unquote acceptable agreement across the aggregated 11 clips, there was a huge drop-off that we see to unacceptable levels in the 2 clips where the wall motion did not correlate with valve motion. Moving forward, we hope that this highlights a potential pitfall when we try to interpret cardiac standstill in our patients. So what does it mean if there is a small twitch that doesn't cause any valve movement? What does it mean if the valves are still fluttering for some reason, maybe due to slight blood flowing or blood swirling due to ventilation, but the walls are no longer moving? Does true cardiac standstill require every single structure of the heart to remain completely static? One might argue that a small twitch that does not cause movement of the valves or other structure is also effectively a cardiac standstill in a clinical scenario. This hopefully goes without saying, but ultrasound should not be used in isolation to determine when to stop or continue a resuscitation. We must always consider the clinical factors as well as the duration of the arrest. So we do have important literature, for example, interpreting after we know that basically after 20 minutes of out of hospital cardiac arrest where EMS resuscitation has been initiated, the survival rate drops from 9 to 2%, and that's after 20 minutes of CPR. Even worse, the 30-day favorable neurologic outcome drops from about 2% to less than 0.5% after 20 minutes of CPR. So, for example, if we interpret a video clip with a minimal twitch as ongoing activity, is this going to lead to an excessively long resuscitation in a child that doesn't lead to any meaningful survival? Ideally, we hope this research really just helps foster a discussion among our academic societies that helps lead to the creation of a detailed and more consensus definition of standstill for use during our pulseless arrest cases. And then finally, just thank you for listening to the presentation. And if you're curious about seeing all of the study clips, you can actually use this QR code, which still works. I just tested it. I can stop sharing as well for any discussion, or I can keep this up for discussion in case you want me to go back any slides.
Yeah, why don't you keep it up? So I'm curious about a couple of things. I'm wondering if you can share with our fellows some of the problems that you had or difficulties that you encountered with the research, since many of them are starting their own research projects, and talk a little bit about how you recruited people to do this. I know your overall participation rate was like 9.9% from all of the folks that you sent it to, and how that might have affected the study results.
So one of the biggest issues is just finding the clips. So clip acquisition. Cardiac arrest in children is fairly rare. And then actually having a point of care ultrasound clip of the arrest that was saved in the moment. And then on top of that, actually having a somewhat quality image. If you download this QR code, you can see that not all the clips are really created equally as well. So I think one of the issues too is just kind of quality control for your clips and trying to assess your sense of quality control. I think using stats like a kappa between the study authors and maybe a third party is a helpful means of achieving that. In terms of the survey participation rates, surveys are notoriously hard to get high participation rates in. It's definitely a limitation of the study. I think the fact that we had 9% is somewhat admirable. And I think even having that high of a percent response rate is related to the fact that this is maybe a somewhat more engaging topic for people. I think there is possibly a sense of morbid curiosity or people just having a sense of anxiety for when they are running a cardiac resuscitation in a baby or a child. So I think there might have been a little bit more onus for people to respond or at least click on the survey. If that helps answer the
We have a pretty small group of pediatric EM ultrasound groups. So we would approach them specifically and then have their own institutions with their learners also participate in it. So that was very helpful as well.
That's a good idea to get to the audience that you really, I mean, it looks like you were really kind of focused on that subgroup.
Yeah, and ultrasound's a pretty small world, so I think it came together a little bit on this one.
Yeah, and PEM is an even smaller world.
Yeah, exactly.
All right. Anything else you'd like to add, Dr. Tay?
No, I think our clip acquisition mostly came from a database. Actually, it's not common at all to have a resuscitation being performed that with a saved image. We can't even save our regular FAST exams, let alone resuscitation. So this was very valuable for us to even get this. So we really appreciate our other study members who contributed to the study to make this happen for us. And I think overall, this was a really great study. The study was from the adult study that came out of Sinai. So if you want to reference that, some of the study, Kevin, who also was the first author for that study on the adult side. So that idea stemmed from them. So I appreciate also their input on this.
Yeah, that's the original adult study on agreement and standstill for adult resusces.
Yeah, the idea for the study is that you can go on and on with pediatric resuscitations because nobody wants to stop. for a child. They just, you can do this for like 2 hours if you want, because there's no reason for you to stop. We don't want this so that there's any discrepancies. Well, there's going to be controversies as to when to stop. If you see just blood swirling, you're going to interpret that as there's still something happening. So you're going to continue resuscitation for another hour, which in these cases is not fruitful at all.
Yeah, I really like your recommendation of having ACEP and the College of Cardiologists really define what standstill is, if that's possible. I don't know if it's a combination of lack of ventricular wall motion or lack of valves, or when you see the swirling blood, but it would be nice if there could be a consensus so we would all feel like we're acting the same on the same we're treating patients the same way. And I don't know if there's been any study to actually look at the resuscitation rates, for people who had valve movement or anyway.
Not that I could find. I was looking.
I bet not, not even in the adult population.
No, unfortunately.
And I don't think people would want to be the ones that's going to step up and say, okay, once you see none of this movement, then you can stop resuscitation, because what if that's not the case? So I don't think anybody wants that responsibility. So it's kind of hard, I think.
Yeah.
For them to commit to it.
Yeah. My takeaway was, I think standstill is helpful in getting you to stop, but seeing those twitches, I think you should take pause about continuing the resuscitation, and you should look more at how long have you been doing the resuscitation and what's the status of the patient and the arrest.
Mm-hmm. All right. I'd like to open the floor up. If anybody else has questions or comments?
Can I ask a few things?
Of course.
This is awesome work. It seems like it mirrors pretty well the adult findings. I think one of the questions I had is, I didn't see, I might have missed it in the supplement or something, but a description of the patients. Are these like young kids? Are these like infant arrests? Or are they kind of a big spread of ages? And are there any kind of more adult physiologies? And my other question, more of a big picture, I've talked to our PEM folks and they're like, yeah, we don't really use ultrasound in cardiac arrest because we don't really know how to. Like, we don't know what to do with that information. How do you all use it, and how do you teach your learners to use it?
So for me, I can think back to one anecdotal case, and just to answer the first part of your question, this was a range of both like infant to teenage physiologies. And so I would argue teenage physiology is effectively adult physiology for the purposes of focus of the heart. And then regarding the second portion of your question, I have used it in my cardiac arrests, and it's really been as a tool so I personally will carry 40 minutes of total CPR time for a child in cardiac arrest is my personal style, assuming it's not like a hypothermic arrest or there's some other issue going on, or that you're intermittently getting ROSC at certain points. So I'll carry it out to like a 40-minute time period. And I will use the point of care ultrasound to like demonstrate to maybe a family member that there really is no movement going on. If there is slight movement, I won't use it in my decision making at all, is how I've used it in my children. I don't know if E has a different opinion.
Yeah, I think I find it most helpful is to confirm that the cardiac arrest has occurred. And then there's standstill, and then we won't be continuing the resuscitation, especially at the presence of a family member. I think that's probably the most helpful when they're right next to you, watching everything that's happening. And at least in pediatric resuscitation at our hospital, we do allow the family members to be at the bedside to join the resuscitations, and they watch the whole thing. And we actually invite that for the family members.
Yeah, the other thing I would say is helpful during my like resuscitations for small infants in cardiac arrest, it can be challenging for the team at the bedside to palpate the pulses in a child that's small and just locating the pulses. And so outside of all the literature looking at just using a linear probe to gauge return of spontaneous circulation, having a probe on the chest as well can be somewhat helpful in kind of determining like should we be looking a little bit harder or in different places to see, can we feel a pulse? Just anecdotally speaking, it can be hard to find the pulse in a small infant in arrest.
Yeah.
And a lot of people, when they did this particular study, they participated in the study, they had asked me, so then what happened? What's the right answer? And I just have to let them know that all of the patients who are on the study clips all have passed. They've all died.
Mm-hmm.
Yeah, this is interesting. I can't say that I have used ultrasound in our pediatric arrests. So I'm going to start using it because we see a fair number here at Metro. So I'm definitely going to take a look and see. I have to tell my other ultrasound faculty, to do the same, and probably some of our other faculty. But I think it's actually a really good thing to do, and would be very helpful in research. All right.